This is Eric Connor, and today we're going to talk about the adoption challenges of EHRs. EHR adoption has increased steadily since 2010. This is primarily due to two key players, CMS and the HITECH Act of 2009. Those two played a significant role in increasing the rate of adoption for EHRs by investing over $20 billion in the EHR implementation. As of 2015, 84% of non-federal acute care hospitals have adopted at least a basic EHR system. And despite this growth in usage of EHRs, challenges still persist, mainly in interoperability, usability, and health IT safety. EHRs have many capabilities, including better engaging patients and families in their healthcare while improving population and public health outcomes. Literature supports that EHRs can reduce medical errors, can provide better communication among clinicians across disciplines through the sharing of data. Literature also supports that it could lower national healthcare costs and better manage patient health records. Ultimately, this improves the coordination of care and healthcare quality of patients. Meaningful use was designed to establish criteria for EHRs so that they could be utilized more efficiently and effectively for patient care. It evolved over a 5-year period from 2011 to 2016, with the first stage focusing on data sharing and capturing. The second stage aimed to advance clinical processes, and stage 3 aimed for improved outcomes. To be eligible for meaning use, the ONC had to certify the EHR systems and ensure that they have the technology capability, the functionality, and the security to meet meaningful criteria. The Medicare Access and CHIP Reauthorization Act encourages the use of EHRs through incentive payments for care that's given to Medicare patients. This is a value-based payment program aimed at moving healthcare toward value and performance. And under MACRA, the merit-based incentive payment program will replace the EHR incentive program that was there previously, utilizes measures to calculate a score for eligible professionals, resulting in no deduction of payment, a reduction of payment, or a bonus tied to exceptional performance. What this ultimately does is hold physicians more accountable to the cost and quality of care that is given to patients. Now we're going to venture into some of the adoption barriers for EHRs. One is being a legacy system. Legacy systems are actually very prevalent in today's healthcare. These are characterized as very being outdated old systems that have trouble in incorporating some of the recent technological advances in information and communication. These have been known to be very difficult to maintain and evolve, and also costly for redesigning and replacing these systems. A common challenge when working with legacy systems is to transfer this data from these old systems to new systems, which may not be very compatible, leading to potential for missed or lost patient information. One adoption barrier is interoperability, which is sharing communication and data across organizations and between providers. This has been challenging for organizations because the development of EHRs included different platforms with inconsistent standards. There's also a lack of universal patient identifier, in addition to the technological complexities of pulling from a range of sources. And there also, unfortunately, is a lack of incentive to provide interoperability, which leads to information blocking. Information blocking is the known interference or blocking of information between providers and organizations. Ultimately, this hurts the functionality and efficiency of EHR. Another adoption barrier is usability. Users often find that EHRs are simply not user-friendly. This can come in the form of confusing displays, or not supporting the physician's cognitive workflow, or the way that the data is presented makes it harder to draw conclusions. Still, another adoption barrier for EHRs is health IT safety, which is really the technological components of the system itself. This can come in the form of a mismatch between information needs and content needs. There's also concerns of software modifications or upgrades and configurations. And there's also reports that one component can unexpectedly interfere with another component of the system. Ultimately, what this does is demean the trust of providers when working with EHR systems. Recommendations for interoperability really need to begin with consistent standards. We also need to strengthen penalties for practices that deter interoperability, such as through information blocking. Transparency needs to be better between vendor and providers, and also making reimbursement contingent on interoperability. Recommendations for usability center around collecting data of the user's perception and working to make a better interface for them. And also adopting best practices for EHR implementation and performing education on the safe and effective use of EHRs and monitoring and responding to adverse events that are reported. Recommendations for health IT safety include adequately testing the EHR along with simulations of the technology to ensure that it's working properly, while also placing safety features throughout the implementation process and providing a way for users to report adverse events and using that information to make the system better. In conclusion, despite the benefits and capabilities of an EHR, a fully functional and integrated system has yet to be realized. A lack of standards, incentive, and trust really impedes the ability of this fully functioning system. Establishing trust between key stakeholders, providers, and vendors is paramount in creating an EHR that realizes its potential and improves the quality of health for millions.